Good afternoon, everybody. Rhys Pierce from Footwork back with another session talking to some of the fantastic podiatrists around the globe. And today, very fortunate to be joined by Dr. Chris Bishop. Bish, how are you going?
Very good, Rhys. Good to see you, mate.
Yes, likewise. Thank you for joining me. Chris, you're the director of the Biomechanics Lab. You're a research consultant with ASICS. You have a PhD in footwear design and orthotics specifically for plantar heel pain. You're a senior research fellow at UniSA, and you're a very close friend of myself. Thank you for joining me. Today, we're going to be talking about a little bit about how you incorporate orthotics into your practice. You have a very unique clinical practice, and specifically the modification of the CB arch modification.
100%.
Talk to me about that, Chris.
Yeah, I think, mate, maybe just give a little bit of context, I guess, about where this all came from. So, in terms of executive summary of clinical practice, most of my work, sort of post PhD, post clinical, has moved into the management of the complex foot and ankle, whether it's arthritis, orthopedic surgery, do a lot of work in the defence force, but we also do a lot of work in sort of sports medicine with cricket, football, netball, where we consult to a range of the teams, both myself and the team here at TBL, here in Adelaide. So I guess one of the things that we routinely see is so much sort of musculoskeletal pathology associated with, we typically call that flat foot, whether that's structural, whether that is a deficit in tibialis posterior control, like an eccentric deficit, whether that's hypermobility or whether that is structural trauma associated with that. So we've always been on a clinical journey here to be able to best understand how to analyze that. And I guess one of the things that we learned in my PhD, and maybe the luxury of us having a 3D gait lab here at TBL, is force is kind of what does the damage to a lot of these tissues. You can have a really flat foot, but the thing that overloads it is when the external force being applied on the body exceeds the internal capacity of that tendon or that tissue. So we really, started with that theory. And I guess clinically, one of the things we say to our patients all the time is, Rhys, when you walk, a force is applied to you. You either have the capacity to handle that load or you don't. If you did, you wouldn't be sitting here. So my job is either to increase your internal capacity to handle that load or to modify the external force being applied on the system or on the foot and ankle. And we obviously use orthotics to be able to modify that external force. So when we were looking at our PhD, or my PhD, and one of the things we looked at, we ran a randomized control trial of people with plantar heel pain. And there's been some really great research out there, particularly by the Latrobe group with foot orthotics and plantar heel pain. But it's routinely used in prefabricated inserts. And my clinical judgment is that everyone is different, and the dose that they require based on their individual foot biomechanics in terms of external force addition into the system and really trying to unload tibialis posterior, the plantar fascia, and those medial structures, it needed to be patient dependent. So what we identified through some of our master's work and even our clinical practice here at TBL is the individual motion of the subtalar joint and the mid-tarsal joint needed individual strategies in orthotic design. And so if we look specifically at the subtalar joint, one of the things that we worked out is there are modifications historically, things like the Kirby heel skive and, Blake inverted devices and those sort of things that work. But if we look mechanically, they either largely work in the coronal plane. It's not really a true triplanar device. And particularly before the lines or the times of 3D printing and computer-assisted manufacture, where it was plaster work, it's kind of like you get out the burr grinder and you're trying to self-locate the position of that. What computer-aided manufacture and particularly 3D printing has allowed us to do is be more specific. So we came up with a modification. Yeah, we called it the CB for obvious reasons, and obviously we did that with footwork. in terms of the ability to really go, how do I get something in the sagittal plane as well as the coronal plane as well as the transverse plane? Because my belief is, and I guess if we try to get a foot, if I can stop the calcaneus plantar flexing in terms of sagittal plane facilitation theory, but if I can stop the calc plantar flexing, I'm then going to really limit the out of plane contributions of that inversion and abduction motion. So the idea about the CB was to mimic the function of tibialis posterior in its complete form, where it's both trying to plantar flex as well as invert. So if we reverse engineer that, we want any orthotic modification to essentially apply a dorsiflexion moment on the calcaneus as well as an inversion moment about the subtalar joint. And that's where the idea came from.
And so, I think it's important as well, correct me if I'm wrong, to recognize that calc plantar flexion is the first movement
100%.
in rear foot pronation.
Yeah.
And I don't think there is any other modification that I've ever seen that supports the literature that suggests that that's the first movement in the foot pronation.
You look at every joint in the foot, mate. Like whether it's the midfoot through arch, whether it's MTP dorsiflexion. This is a really simplistic version, but if you've got sagittal really well optimized, you've probably got most things. And I say it to a lot of my patients, if it's an Achilles peroneal, if I can get the heel vertical and not necessarily structurally vertical, but if I can change the moment arm, and if I can reduce the magnitude of that moment arm acting relative to the subtalar joint, and therefore reduce the amount of work tib post has to do in the peroneals on the outside, I can use my calf muscle more efficiently. I can use those midfoot intrinsics more efficiently. And I routinely talk to my patients about getting in the most structurally stable position and the center of pressure within the midline of the foot. And I want to reduce the deviation, medial or lateral. Okay.
Yeah.
And you can have the same concept laterally as well. That's probably a whole nother conversation and another video, but it's the same. If you've got a foot, cavo varus lateral instability, you can apply the same concept to the lateral aspect of the calcaneus, proximal to the calc cuboid joint, to apply a net eversion moment as well. And it works really nicely.
Yeah. It's important to recognize, the opposites and purposes of the opposites as well.
Yeah.
So we touched on the theory of the CB modification. You would use it largely in combination with an as-is style device. Is that correct?
Yeah. One of the whenever I design an orthotic, I try to look at every level. Okay. What do I need at the subtalar joint? And then what do I need at the mid-tarsal joint? Yeah. And again, probably topic for another video in terms of what we do about the mid-tarsal joint control. But in my prescription, it's like, how am I pouring it? What is essentially my general arch profile? And I do use an as-is at 0 more than just an as-is, because if I want to try and create a little bit more inversion, therefore more effect about my CB, I don't want to necessarily increase the height of the medial longitudinal arch, because I'm trying to address the supination moment around the subtalar joint.
Proximally.
Yep. Yeah, not necessarily that and the mid-tarsal joint as well. And so we can use wraps and arch heights, and we play around with that separately. But I'm very, very specific in the use of the CB as a subtalar joint modification, not a foot inversion. And that's really important. So I've got lots of patients that need a CB and subtalar joint, yet they might have a raging forefoot valgus with hypermobility, and then I run something laterally. So the last thing I want to do is supinate the whole foot and then create more of a lateral instability. Does that make sense?
Absolutely. And you touched on it briefly, and obviously not the point of our discussion today, but that's the perfect use of the as is at 0 compared to the as is, where you're not increasing, that medial longitudinal arch height at the ratio that the rear foot inversion is increasing. But we could talk about that for probably another half an hour or so.
100%.
So what do you use the CB for? Let's talk about clinical indications.
Yep.
and then I'll ask you what you don't use it for. So tell me what you're prescribing the CB for clinically.
100%. Oh, I want to show you two things. First, let's just come back. Largely, I'm using it to assist tibialis posterior to do its job. So I might have a plantar fascia, insertional, or it could be a proximal tear. It could be tibialis posterior. It could even be an FHL, tenosynovitis. It could be peroneus, long as it doesn't matter what it is. At the end of the day, if I've got musculoskeletal overload, or if I've got the external load being applied on the system exceeding the internal capacity, the role of an orthotic, and then not only the modification, but shell stiffness and all of those things, is to assist reducing the load on that muscle by adding in an orthotic reaction force. Okay. So that orthotic reaction force changes the position and orientation of the ground reaction force. So if we think about tibialis posterior, and let's just say it's going to attach not only into the navicular tuberosity, but then wrap through underneath the midfoot, the biomechanical correction to unload that has to be proximal. It can't be the height of the medial longitudinal arch, because the biomechanical correction is in front of where the tissue is essentially attaching, and therefore you're going to get no mechanical advantage of that. I want to just share my screen if I can for a second, mate. And I think this will give a nice example. You can see that?
I can.
Yeah. So if you look at this is an image of a real world patient of ours, and I apologize for the dorsiflex big toe. But ultimately, what you can see is this is the CD, and where it is pushing into the foot is right on that medial tubercle. It's not up at the level of the medial cuneiform, and it's not even distal talonavicular joint. It's very much aimed at that sussum taculum talar. Now, a lot of patients, or a lot of people, when I've shown or talked about this device, going, doesn't that compress right on the medial tubercle of the calcaneus? And I argue that it doesn't, because the correction is almost in front of where that pure enthesis is. Now, if I do have a really raging plantar fascia, you can then always add a sweet spot right in on where that sore spot is, okay? But the important aspect is you have to get the orthotic correction. You have to get it pushing on the subtalar joint to create the biomechanical effect. And that leads into a really important point where you can't, like, this is a less effective modification on a concave device, or even a concave with a lateral. Like, it works, but you need the heel height, but also really laterally. You can't use this and then go and pour it at 10 degrees, 15 degrees inverted, because you're going to create lateral instability. You're going to slide off that. And so I almost always, and you see my prescriptions, I almost always pair this correction with a slightly elevated lateral heel cup, making sure that it still fits into the shoe. And it's almost like I'm bucketing it from both sides. I'm creating a correction around the subtalar joint, but I'm ensuring that that doesn't invert, whether it's lateral instability, subfibular impingement, whatever it may be. I'm making sure that it does not overcorrect and the patient is still supported, because I want to hold that calcaneus ideally vertical. I want to create that inversion moment, but I don't want to create inversion of the calcaneus, because that's going to change the mechanical advantage of my Achilles tendon.
So for those listening now, essentially what you're saying is when you use this CBR modification, typically with an zero as device, you're also prescribing something like a traditional with a high medial lateral or a long lateral heel cup.
Sometimes almost like a higher lateral heel cup rather than long lateral, just to make sure we don't get an irritation sural nerve base of fifth, calc cuboid, that area. Yeah.
Yep. Fantastic.
Yeah.
I think you've summed up everything really well, Chris. Are there any other points that you want to talk about today with the CB?
No, I think the only thing, and obviously happy to catch up again, mate, to run through a range of things. So I think if I can just really emphasize the fact that this is a modification that's on the subtalar joint, not elsewhere on the foot, and can't be used in isolation. You have to understand what are you trying to do at every level of the joint. And simplistically, when I talk to my staff about integrating this when they join TBL, it's like you've got to have a strategy about your MTP, what you're trying to do. You've got to have a strategy around your midfoot, and you've got to have a strategy around your subtalar joint. And the key consideration here is understanding what are you doing at the subtalar joint and what are you doing at the tarsometatarsal joint, and then understanding if you're adding this, what else do you need to do? Because I like the idea of this, particularly because I complement this with a proximal LBB quite often. Like I might use a 3 mil device, but that proximal LBB, which just stiffens that area right there, is a really nice. It doesn't make the incline anymore. It just increases the stiffness. So then if you increase the stiffness, you're increasing the magnitude of the moment because you're increasing the external or the orthotic reaction force. But it doesn't mean that the arch needs to be stiff. Okay. Yep. And so you can go 2.5, but then increase that 3. And so you can start changing around with those variable stiffnesses. And that's really important in my athletes, particularly my runners or netballers who are jumping, who need some form of compression about the medial longitudinal arch, but need stability and unloading of tib post.
Fantastic, Chris. And we've discussed quite a few complex terminology and case studies in our discussion. You're obviously very receptive to people, whether it be in person, at conferences, etc., discussing 100%. This level of biomechanics. And similarly, the podiatrists, myself included at Footwork, really love workshopping this high level complexity and 100%, ability that we have.
We've got a great relationship and, obviously part of the wider Footwork family. So if anyone ever wants to reach out to me, my email is just chris@thebiomechanics.lab.com.au. More than happy to have this conversation and, jump on a chat anytime.
Chris, thank you so much for your time. Hopefully you're not too far away from a wine this afternoon somewhere in the Barossa. Thank
Maybe
you
again. Adelaide Hills this afternoon. But
Adelaide Hills this afternoon. Fantastic. Thanks again. I'm sure everyone's going to get a lot out of it. Thank you, mate.
Good to see you.